Welcome to Health Law Talk, presented by Shahardy Sherman Williams. Health law broken down through expert discussion, real client issues, and real-life experiences. Breaking barriers to understanding complex healthcare issues is our job.
And good morning, good afternoon, whenever you're listening to this podcast. Welcome to another edition of Health Law Talk here at Shahardy Sherman Williams. Conrad Meyer here behind the microphone and giving you the best and greatest of healthcare compliance, discussion, regulatory, and just overall social issues dealing with healthcare in the United States. And today we have a really good set of guests on our show that we're going to talk about a multi-part series here. It's going to be restoring trust in the United States healthcare delivery system, or United States healthcare. And in that context, I have two healthcare executives on the podcast show, David Laird and David Bryant, who I'm going to introduce now, who are really expertise in their field and have agreed to come on the show to talk about this important topic. I'll take it to David Bryant first. David Bryant, introduce yourself and tell us a little bit about your background.
Well, I'm glad to be here. I've been looking forward to this. Yeah, I was trained as a hospital administrator, and I've been at it now, and I can't believe this, for about 30 years, in and out. But my formal background was in hospital administration and worked for several companies on the administrative front. And then I worked also doing mergers and acquisitions for a publicly traded hospital company as well for several years. And so, you know, it's interesting just with that experience, having, you know, the optics that both David Laird and I have to kind of look at what's going on within how our response was to the pandemic mainly, and what we can do good, what we did, you know, medium, what we did bad, and what are we going to do next time. So anyway, that my experience is in that space in the executive C-suite of hospitals typically.
Nice. Well, that's very good. We're very happy to have you on the show, and we're looking forward to this wonderful, I think, timely discussion. And then, of course, I can't forget about David Laird. David, tell us a little bit about yourself and your background and what you intend to discuss today.
Hi, Conrad. Thanks for having me. I appreciate the opportunity to be with you and to talk about these issues. I have been in healthcare administration for almost 40 years. Started in healthcare administration straight out of college and worked my way up through the executive ranks in the first 2/3 of my career in hospital finance, working my way up to chief financial officer. I was chief financial officer of 3 different hospitals, and then became regional chief financial officer overseeing 10 hospitals in that role, and then ended my career with a tenure of 16 years being hospital CEO, and I retired from full-time work last year. I do a little bit of consulting now. I'm on the board of a couple of organizations, but have had my entire healthcare career in hospital executive management.
Well, that's great. It's obvious from both of you that y'all are both well-versed in hospital administration. And I could, obviously that's a big deal. That was some of my former history when I was going through this years and years ago. And so I thought this was a very, very timely and good topic that we can discuss about basically, I think the public's and even some providers, within the provider ranks of the mistrust or the motives, right, of healthcare in the United States. And so with that, I'd like to kick it off, to either one of you. What do you see what's going on in the healthcare delivery system in the United States, and especially now through the pandemic issue? What's been exposed? What are you guys seeing?
Well, I'll tell you, I will kick this off with one of my favorite sayings, and then I'm going to let David kind of take it away. The United States does not have a healthcare system. We have a healthcare industry, and that has served us well in some regards, but completeness and comprehensiveness and overall well-being of citizens in the United States isn't one of the primary criteria for a healthcare industry. And so, during during times of crisis, you basically don't have one voice in the room. You've got all kinds of people trying to do what's best for their organizations. And so I like David Bryant's idea of taking this in the direction of restoring trust in the healthcare system, as it were, because we essentially have never been more divided and kind of do not think that things were all done in our best interest. So with that, I'll pause and throw it David's way.
Yeah, nice segue off of that is one of the, as I was kind of thinking through, just taking a look at just today and where we've gone, where we've been, and David's so correct that it is as divided as ever. And I wanted to look at it from, okay, if we went through this again, let's just say we had another nasty virus that we were dealing with, and having to respond to it. And I think I would say the same as many providers would, is that if we looked at the communication downward from our public health system, I would say that broad term, and that would include everybody from the White House to the CDC to NIH, et cetera, is if you go back in time a couple of years, I don't know how long back, but starting at about 4 o'clock Central Time, you had the White House coming on with 4 or 5 experts behind them, clearly hadn't huddled on the message very well. And so, and then, it morphed over to the press, that it was a very fragmented conversation about what we were doing, what we should do, what happened, all the things that the public really needed to know.
And we're talking about the COVID in March of 2020, or was it
2020? Right.
2020,
okay. Yeah.
Okay.
That was when that was in my world. That's was when the kind of the chaos started.
Right.
And so because of that communication, that fragmented communication, we had a lot of fear, anxiety. It depended on many, many factors. The messaging was not very consistent, and it wasn't comforting at all. And so, and then when it got, from the very beginning, that was a little messy. And then as it got politicized, which made it way worse in terms of that messaging, because then you were having people attached to one or the other side, and you weren't getting at the problem. For me, this wasn't a political matter. This is a public health problem. And I think those of us in the industry, that's kind of where you go. You go, let's work on the public health issues. And that involves a ton of different aspects, which is, how do we respond to it? What do we identify the disease? And what population is it affecting? It's just a lot of the things that, you would do. And it just seemed like it got for a longer period of time than I thought. It just became this political football back and forth. You like this, you're on this team, you're on the other, and which is kind of silly. I mean, when you look back at it, it's kind of ridiculous. But that's where we were, and we probably still are to a certain extent. Although I think that's settled down a little bit. So I say all that to say I would really encourage, and I don't know that I certainly don't have all the answers. It's a complex question. We've got to get this system streamlined to where this communication is. We have a plan with which to communicate this as a single voice, and to the extent that we can't keep it out of the politics, because that does nothing.
And I guess, okay, you're referring to the COVID message that came out from the White House back in March, and of course the mixed messages that we were getting at the time. And sort of how do we create sort of a top-down communication style? Is that what you're referring to?
That's exactly it. And again, we were in a chaotic time. And so to have all this, I can be very, idealistic about this to say, but we've got to get a singular voice out of the public health officials that can speak to this, and that can, they're not all going to agree ever. We know that. I would really like to see that.
I've got an interesting hot take on this.
Yes.
I think our system in America is based upon capitalism, and we did the exact right thing, I think, with asking individual corporations, entities, to come up with their best shot for a vaccine. And of course, the mRNA vaccine technology was the newest, latest, and greatest. It was 10 years in development, but had not been used on a wide scale until this event. And so it almost is this inherent kind of conflict between not being able to have one central voice because you had different formulations of a vaccine. I still contend that the only way we can look at this is through the prism of the information we had at the time, because you work with what you know at the time, and you know, it's easy to second guess years later. But working with what we knew at the time, you know, we had 7 different companies trying to make a vaccine that would work. And so I like the incentive that we built in to have different companies. And yet I think that hindered the government's messaging because there wasn't one thing. And then ultimately you had this individual liberty argument of people saying, you know, the government can't tell me what to do. And that's right. That's what we have in the United States. But we had no limits that were established or kind of even a framework agreed to on if somebody chose not to get vaccinated, you know, did they have any curbs in their rights, their access to society? So it's a fascinating thing. I'm kind of more on the pro-vaccine side. I continue to think it probably saved lives, and yet a lot of people, many people in our country now think that it was a conspiracy theory, and there's, you know, all kinds of negative things that happened as a result of the vaccination strategy. I just think that's mostly hokum, that it has conspiracy theorists gone wild in retrospect. But there's vaccines that have prevented a lot of disease in the world, and I don't think you could just wash that across and say that vaccines are negative and bad. So I'll pause there for you.
No, and I think that's all a good point. And let me just ask you this, okay? So because we're focusing on the dissemination of information regarding the COVID response, and I wanted to ask, was there, and that sort of exposed sort of this sort of fractured viewpoint between varying agencies and even individual providers, et cetera. But do y'all believe that was the first time this sort of fractured viewpoint sort of exposed sort of a broken, or really to your point, Laird, that it was an industry, not really a system, or had it been, you know, has this been going on for quite some time, not with respect to COVID, right? But before that, I mean, has this been a broken system before that, or did it just sort of appear post-COVID?
So I think we've had the bones of this for a while that never got resolved with universal health care. Essentially, that we're pretty widely divided on whether the government should provide health care in the United States. And there are people who can speak more eloquently than me, but we're the largest nation of the top 22 that doesn't have a government-provided health care system for every individual. And so we remain the kind of the outlier in that regard. And so even the fight for Medicare and Medicaid and all of that, you see the states' rights issue. So it becomes complicated that we can't even get agreement on how you provide health care and how you deliver it to the citizens. And then we layered this, you know, once in a 100-year event on top of it. And it kind of made people go into their particular points of view corner about what the response should be. So I think we've not resolved healthcare in the United States. We've actually made the camps more entrenched of whatever viewpoint you had.
Now, some would say, I'm sorry, go ahead, David B.
No, I was just agreeing with that. And that, you know, this again goes back to this virgin territory, and we got tested, and I just don't think the structure of our system, top to bottom, was not optimal for this, for the crisis that we had. And so in the spirit of trying to be more prepared for next go around, the open dialogue that needs to happen between providers, you know, I also felt like our physician-patient relationships were kind of thrown to the side. And even when some of the physicians were asking questions, it was like they were quick to be almost silenced and not really given a platform to keep an open dialogue. And I think that really hurt us in the long run too. How they were kind of corralled, which really surprised me. But anyway, go ahead, Conrad.
Yeah, I think so. Let's talk a little bit about that, okay? And to respond to some of this, now I'm going to play devil's advocate here. So some would say ACA, the Affordable Care Act, was the solution to universal coverage, and with the ACA and these sort of state exchanges, et cetera. And we're not going to get into the whole how that works, but that, because that's a very complex issue. But that was the solution to the universal coverage. And I just wanted to get your thoughts, both of you, on, because that's what some would say. Some would say, oh, wait a minute, we do have something, and we do have the charity system, and we do have some things in place. How would you respond to critics who say, well, wait a minute, before we take that leap, ACA did answer that call? How would y'all respond to that?
Yeah, David Laird, that might be best in your wheelhouse, but I do have some thoughts on it.
Well, Conrad, Texas, I live in Texas, Austin, Texas, and it's interesting that still 10% of Texans are not covered by health insurance. And so it's a suggestion of the system to say that everybody's got coverage now. And the fact that you can't access mental health care services, even through most of the ACA products, I would still contend the ACA might have been a start, but it really is for people that couldn't get coverage in a lot of other different ways. Different avenues, weren't eligible for Medicare. So it still has a lot of holes in that system, and it is not coverage in the way that most nations, developed nations, think of a healthcare coverage vehicle.
Got it. Okay.
Yeah. And I don't know that I have much to add to that. Between Medicare and Medicaid, this is probably looking at a global, we cover, 75% of the people between those two programs. And then the balance of it are the commercially insured population, and then the 10% that David was just referring to. So, I mean, we've got there's definitely holes in it, and that's been that we've had this conversation for as long as I've been in the business.
Yeah.
I think, as to how to solve that.
Well, and it's the coverage versus access, right? I mean, and we can go into that, and I think because this whole topic that we have now, we're going to dedicate some time to this on this multi-part series, is so complex. It's got so many facets, so many different players that I don't think anyone can even cover it. I mean, in a single, it's just too complex, too many players.
I think you're right.
And so that's why this was a great topic that I have to, tip my hat to both of you, because I think it's so important and something that I hear on a daily basis, even from my standpoint as a healthcare attorney. So let's kind of delve into that. So when you get into coverage versus access, and I've been saying this since ACA, you got coverage, but do you really have access? And I think there's two different points, right?
Yeah.
What do you guys see in your facilities with respect to that? Is that something that y'all can talk about? I mean, what do you think about that with respect to, and we're going to circle back to the COVID pandemic on the message, but I just wanted to talk about the coverage access. What do y'all think about that?
Yeah. Well, I mean, I'll throw in a thought. I live in Houston, massive medical center here, and on the access side of it, you've got your public hospitals that are, in our case, Bentob, that in situations you can access it there. It's not. I'm sure it's not ideal for anybody, frankly, but we have that somewhat covered in terms of just indigent care rules that have been put in place that patients can't get turned down, et cetera, et cetera, et cetera. But so that would be my comment on the access side. And I don't know if that's completely on topic or where you're going on that, but
it doesn't have to be. I've always the problem I had, and I've seen it on the legal side, right, has been, you got coverage under ACA through the various exchanges, right? But then do you really have the access? Because you see more providers opting out of Medicaid and opting out of Medicare for these concierge practices. I mean, I don't know if were y'all seeing that in Texas? Was that happening in your area?
Yes, absolutely.
Yeah, for sure.
I can give you my specific example without giving too much of my own information. I retired not eligible yet for Medicare. And so the products that are available on the open market, after I've been paying insurance premiums for my employer for the past 38 years, essentially I can get one of those products you mentioned on the ACA and then have almost no doctor that I currently see, me or my wife, providing service on any of those plans that are available in my geographic area. So there is coverage that you can get and pay for, but really access is a whole different issue.
Right.
And the point you're making, I just would say there's a huge disconnect, and it's why there's not portability. A lot of people are keeping jobs that they have because of their benefits package, which includes insurance. And I think we would have a freeing up of a lot of employees who would change jobs, move jobs, if they didn't risk losing health care because of it.
Right. And
I agree.
And that's a whole, we can talk about, that's a whole nother spinoff on access and coverage that I think we can get to, and we can make it part of the series if you'd like. But I think it was an interesting point to make because of your comment, Laird, about industry, healthcare being industry. And so industry, like you mentioned, doesn't care. Like, in other words, it's on its own island. Each facet of that industry is on its own island. So you've got facilities who are competing for their facilities, or systems competing for their own systems, or groups competing for their own groups. So there's no sort of unified, goal here. Everyone's out for themselves. And I mean, am I correct on that? Is that how you guys are seeing it out in your area?
That's exactly right. That's what companies
are spot on.
Yep.
Do.
Yeah.
Yeah, go ahead.
Well, I mean, it's as competitive as it's ever been, really, is that, all you have to do is pick up any newspaper. Houston's is crazy competitive, and we've got big, massive systems here. But it's very, very competitive, and that want to be number one. And and which probably serves the consumer, the patients, pretty good. But, it is an industry that is competitive for the best people, to not only in management but on the floors. So, yeah, it is definitely an industry, and it's difficult. That's always been to distinguish when you're dealing with human lives and patient care and patients' rights, and then stockholder concerns and et cetera, et cetera. It's always been kind of you've always had to straddle that line. And I think we've done a pretty good job with that, but it still is kind of automatically a little bit wonky.
Yeah, and that goes to, so when you're having your competing interest, right, you want to be the number one, as you stated. So that, to me, I mean, that's does that put, and I guess here's a good quote. Let me see how y'all like this: profits over patients. I mean, if I say that term, profits over patients, does that, in your mind, sort of, even if you don't want to publicly say it, I mean, does that sort of ring a bell? Like, man, I can't tell you the opinions I have on that, but I'm saying, does that sort of feel like are providers in, and you don't, if you're not comfortable answering this, that's fine. But does profits over patients seem to be where most people view our healthcare system? What do y'all think?
This is Laird. I'll come in strong here. I think profits over patients absolutely is the thing that we have to overcome, and whether that's guardrails by regulatory kind of issues, or even some within the industry. So I'll say that the best providers in healthcare, physicians, hospitals, health systems, and even insurance companies, are those that take the long view and are indeed interested in distinguishing themselves in the marketplace on their quality, their outcomes. And so I would say, I'm proud to say every organization I ever worked for was trying to differentiate itself positively on quality and outcomes. And so if you do that, the long term is that you continue to positively set yourself apart and hopefully attract customers, patients to you. The short-term implication of that is whether it be an insurer or a hospital or anybody else, the financial viability and profits is the word you've used, it's a topic that's impossible to ignore. And I'll throw one thing, not to get us off on a side conversation, but think about the early.
It's kind of hard not to. It's kind of hard not to in this kind of conversation. It is very wide here. But go ahead. I'm sorry.
Well, no, that's right. In the early days of the pandemic, essentially market forces, people started retiring, getting out of the industry, didn't want to come back to work. You think about nurses who were on the front lines, whether that's an emergency department, surgery department. Think about all of those fear issues that those frontline caregivers had in those early days of a pandemic, because most of us thought if we got the virus, we might die. There was that level of fear. And so the issue becomes, what is safe staffing and how do you ensure that? If you don't have 20% of your workforce, which was a very real number for most hospitals, do you then limit the services you provide? What do you do? It has all kinds of real practical implications for how you then run a service. You could have paid, triple the wages and still not had all of the labor that you would have, liked to have had back in those days. So I'm circling back to around the point of does profit or, in a lot of cases, just financial viability play a role and most of the time a central role in the provision of healthcare? I would say it does in our system, the way we provide it. So I'll pause there and let David Bryant.
Yeah, I'm thinking, and I think this is some good perspective to have from guys really on the front line like David Laird that were having to keep a hospital open. I believe there was some pressure, particularly at his facility at the time, on postponing elective surgeries and all kinds of challenges. You've got a nervous staff. You just did, and they were trying to do the best for themselves, and yet come to work every day and help get us through this. But yeah, what happened back in the C-suites during that time was not easy. And although I wasn't technically in the hospital management during the pandemic much, but it was a challenge to kind of keep the floodwaters at bay when there were just so many challenges, and one of which was going back to the original topic that we were talking about, was the messaging that was coming out to the general public. Because if you look at it, there was a long period of time where you thought everybody was exposed to this, including children and everything else. We know better now. It was focused on a pretty fairly specific, a few outliers, obviously, a specific population. And so having to manage all of that and not knowing what was the next surprise out of the actual virus, really created took some good patience and making some good decisions, with your entity to kind of keep everybody safe and happy. But anyway, that's what went on in a lot of the C-suites, was just trying to figure out this, that, and the other. And really, you didn't know what the government was going to come out with. I mean, this is a whole other topic that we may have to have separately too. And David Laird and I talked about this, is when they threw the mandate card out there, that created another, kind of a mess. And, trying to see where that was going to go. I guess that's kind of settled down now, but that was a good example of, all right, what are we going to do if nurse so-and-so doesn't want to get a vaccine? How are we going to deal with this? And the systems dealt with that differently. Some were very, very harsh. Some were very lax on it and didn't didn't make it a real onerous thing.
Yeah, I saw that hospital in Texas. It was in your area where they fired 600 nurses, or I mean some astronomical number because they refused to get the vaccine.
That was system specific.
It was what?
What's that, Dave?
Well, yeah, Conrad, that was in the city that I live in, and that became a kind of a secondary issue of your company's rights versus an individual right. And I'll just come in on this as well. I think a company does have the right to determine the criteria for working at that system. People may not like it, and this is where this individual liberty argument kind of came in of what trumps what. But in our capitalistic society, I think we give employers certain rights, and a TB test is one of those. You have to be screened for TB if you work in most acute care hospitals in the United States. And people just have had that understanding and basically gone along with it. But then all of a sudden now you had COVID kind of have people question what the rights of those employers were. So while I may not like it, and my organization had a kind of a softer approach to that mandate, I absolutely respect the rights of employers to determine that if you want to work at that organization, because they thought that was what was best to keep patients safe who came into their care. And, again, the side road, you saw what happened in New York with the nursing home patients where active COVID patients were sent back into nursing homes, and one of the highest death rates in the United States. And so I do think there was a real implication with lives, having people not being protected yet by the vaccine. So I kind of would wrap this up in saying the point of saying this individual liberty question, not having a health insurance system, health coverage system, really it just became this swirling mess, and you had to find kind of a home base of your argument. Were you on individual liberty trumped everything? Were you the government had the right to tell you? Now you injected, well, companies now have a say in what you do or don't do. And of course, the right for individuals for all of that was they could just get out. They could opt out. They could not be employed. They could not have, some things that were accessible only to other people. But it just became this mess. So by definition, you couldn't have one central voice from the government because the choice of individuals remained throughout that whole process.
And that goes back to both of your comments about the one individual voice, right? Because I think all of us saw that there were people trying to get out, I guess, different voices, if you will, right, on different platforms that were basically censored. They were taken off. If you didn't talk, the talk or walk the walk, or if you weren't speaking government language that they felt acceptable, suddenly you were just disappeared. You were taken off.
Gone.
Right. And I think, more of that, whether, some people will call it conspiracy, whatever, it doesn't matter. I think, the point of, being able to voice your opinion, whether you like it or not, is one of the founding principles of the country. And so, I agree with you in our Constitution, right? So I agree with, how do we manage that? Should people be left to their own accord to judge for themselves who to believe and who not to believe? And, how do you manage that? That's a big mess. That's a tough one. Real tough.
That's a tough one. Very tough. And, that was one of the things too that concerned me a little bit. And, as we went through this, is even our physicians weren't really allowed to ask a lot of questions. I know a lot of different doctors that have different opinions on all this kind of stuff, but even asking a very basic question is, particularly if it surrounded the vaccines, man, you were really holding yourself out there, and you're kind of brave. It's a lot different now.
I think
our
so.
Doctors, yeah, and now, which was different it was a kind of a change from when I was originally in the business a long time ago, is we have so many employed doctors now that I think that there was some autonomy that they may have lost. Maybe it'd be different. Maybe it wouldn't. I don't know. But I know there were systems here in Houston that were pretty heavy-handed on, you're going to do this, and we're going to also control your formulary of the drugs that you can prescribe, which I thought was a little overreaching. So these are a part of the look-back questions that, was this a good idea or was it not? And, what's going to work? And the conversation that we're having now is an important one to really objectively take a look at, the moves that we make next time. So,
and I think also too, some of the things, I think communication, right? Coverage, access, right? Outcomes, measurements, and quality as sort of the primers for reimbursement itself. Yeah. The players in the game, meaning not just providers, but we're talking about payors, DME, biomed, pharmacy, all of the industry players, right? And so when you get all of that stuff, I think we can really have a lot of different topics for conversation that could open, at least give people more information as to sort of your background and what you're seeing out there with respect to these topics. If we continue down this road on this multi-part series, which I think is very, very important. I think it's great that you guys have decided to come on here to do this. You know?
Bet. Well, I think it's clearly a very complex, topic that we'll be on. But again, I think it's a vital subject to be tackled.
Well,
so I'm glad to be on it.
To expound on the earlier point I said, I think we did the best we could oftentimes with the information that we had at the time. And now in retrospect, there are probably many things that we would do different. And I think maybe covering some of those aspects in the future discussions would provide some value as well. Because I agree with your point about, even though people mistrusted the government and sometimes had this strong distrust of the government messaging, I think we did a very poor job in retrospect for communicating a central message, including, the highest levels of our elected leaders. If there would have been a little bit more of a consistent message, I think we would have had a better chance of getting some consensus about our approach to what we were going to do.
Very good. I agree with that. I'm agree with that.
Great.
So I'm going to wrap this up, gentlemen. I think we've sort of laid the groundwork for really what could be some really interesting episodes down the road on these various topics. So I would like to thank you, David Bryant, David Laird, both of you for coming on the show today and sharing your expertise with the audience. And I think we've sort of hit the nail on the head in terms of, wow, what could we enlighten our listener base with respect to, reinvigorating trust in our healthcare industry or healthcare system, right?
Right. Indeed. I think it'll be a very interesting journey.
Well, fantastic. Well, everybody else, sit tight. We are going to end this episode now on Health Law Talk here at Hardy Sherman Williams. This is Conrad Meyer. We thank you for listening and look forward to our next episode. Y'all have a good day. Take care now.
Thanks for listening to this episode of Health Law Talk, presented by Hardy Sherman Williams. Please be sure to subscribe to our channel, make sure to give us that 5-star rating, and share with your friends. Hardy Sherman Williams is providing this podcast as a public service. This podcast is for educational purposes only. This podcast does not constitute legal advice, nor does this podcast establish an attorney-client relationship. Reference to any specific product or entity does not count as an endorsement or recommendation by Hardy Sherman Williams. The views expressed by guests on the show are their own, and their appearance does not imply an endorsement of them or their entity that they represent. Remember, please consult an attorney for your specific legal issues.